Dr. Griffin is a professor of medicine, health, and society, and he's the founder and the director of the Center for Research on Men's Health at Vanderbilt University. His program of research focuses on developing and implementing behavioral and policy strategies to achieve equity in health and well-being by race, ethnicity, and gender. Dr. Griffin has recently published in the area of COVID-19, and we are super excited to have you. So I'm going to turn it over to you, Dr. Griffin.
Today, what I'm going to do is talk about, I know with a lot of the conversation that you had, with some of the other speakers, I know of a couple of them that you've had, and one of the things that's always tough to do is to follow someone like Dr. Jones. Had I known this, I probably would not know. I'm not going to say I wouldn't have said yes, but nonetheless, it's still important to follow, her and those kind of folks. She's done a wonderful job of leading this work for a number of years. And, in addition to being a colleague, I'm a huge fan of hers and of many of the other speakers that you've already heard from. Today, what I want to do is talk about more of these concepts and issues of language, but particularly this idea of how do you frame the problem that we're seeing in terms of COVID-19? And I want to add the lens of gender. And I know you've talked a little bit about place too, I believe. And certainly I know with talking with Dr. Jones, I know you've heard a lot about race and racism. So I'll touch on that too, but I want to sort of put the pieces together a bit. Let me also start by acknowledging my team back here at the ranch, my virtual team now in the Center for Research on Men's Health. We do a lot broader work than just men's health. We do a lot on health equity, racism in health, and so forth. And so I just want to acknowledge and publicly thank them for all the work that they do. COVID clearly is a global phenomenon. And part of the issue and the reason I start with this is because we have to use explanations that help us understand why the patterns of this phenomena that we're seeing in terms of the pandemic, why is it affecting different groups differently within a particular geographic context? And one of the things I want to use as my primary sort of point of entry into this conversation is an updated version of the old parable of the blind man and the elephant. Well, updating the language as well, the blind people and the elephant, doesn't quite have the same ring to it, but it's more appropriate in this particular day and age. But in the original version of the story, the parable, there were 6 blind men in India, I believe it was, and they sort of had come upon an elephant, and each of them was experiencing a different part or touching a different part of the elephant. And, they were kind of the mind that their particular point of the elephant or what they understood of the elephant was the perfect explanation. They had all the information they needed at that particular point with the information and the lens that they were using to understand it. So one said it's a tree because she felt the size of the leg. One said it's a snake because they felt the trunk. They felt the husk and said it was a spear, a wall, a rope. And we know with this particular pandemic, we have to understand how we're going to address this particular issue and how we're going to address the fact that this, even though it just sort of came to the US within this last year, how do we understand the fact that it's affecting different populations differently? One of the things that we know about sort of this issue is that it's definitely revealed weak points in how we think about health and disease. And one of the most important questions is going forward, how do we engage in uncomfortable conversations that we need to have that can lead to a healthier world? And so that's kind of the main thing that I want to do, is to force us or push us to have those kind of conversations, to think about those kind of issues. And that's going to be the main point that I leave you with, is how do we more precisely define the problem, but how do we sort of empower ourselves to come up with more effective ways to have these uncomfortable conversations? Part of what makes them uncomfortable is that this particular virus and just a lot of other things that we'll get into have exposed how the historic lack of investment in our society and in public health over time has really led to pockets of marginalization that have mostly just been revealed through COVID. So there's nothing new and there's no real surprises to who's most vulnerable, who's most likely to be dying from COVID, particularly when we look at the patterns of who's most at risk and so forth. When I look at this, and one of the things, the reason we just wrote this piece that was a blog on the Gender and COVID website that's out of Johns Hopkins. And the fuller blog, it's relatively short. So the link to the blog itself is there. But part of this is I was seeing the same issue with, as we understood COVID. There were a lot of pieces that I was seeing in popular press as well as in the scientific literature that said, okay, the answer is basically about race, and we've just got to understand it through the lens of race. Well, then others were introducing place and neighborhoods and country and states and so forth. And you see lots and lots of data about, well, each state has a different sort of approach, and so we need to think about that and how that's affecting the issues. And then the last one we need to think about is sex and gender. We know that from the earliest days of the virus in China, when we saw some of the earliest sort of pieces that were from Italy, we were seeing these patterns that were very distinct in terms of mortality rates were higher among men than women. And so there was not a lot of attention initially, or enough attention initially to following the WHO recommendations from years ago that suggested when you have this kind of outbreak, when you have this kind of health issue that comes into a particular context, that one of the first things we need to do is disaggregate by gender. And that was not happening. So you saw a lot of calls initially for disaggregation by sex or gender, disaggregation by race, and now you're seeing a lot more attention even to disaggregating by place. What I'm suggesting though is all of these are important, but each of them is limited. And so part of what I'm going to ask you to do or think about is simply the very simple concept that we need all three of these lenses and more to be able to fully understand how we need to address and attack this issue of COVID-19. So again, my main question here in terms of the framing is why? And so this question of why are there differences and disparities in who actually contracts it, and most importantly, who's dying from COVID? So there's a lot of power, as a colleague of mine, Amani Allen, says, in asking the question of why. It forces us to really dig deeper and think about the origins of the disparities. And we really have to have these conversations, not just in our professional settings, but in our personal lives too. The reason this combination of needing to balance the personal and professional is because our support in our personal life for how we're going to decide to do things like vote or not, follow the recommendations and so forth, get beyond just whether or not we're actually following these types of things and initiatives in our professional lives and roles, whether it's in medicine, public health, or other related fields. So all of that becomes really important. This idea of framing is not, again, something new, but there's 2 points that I want to make in terms of how to understand the way that we frame a particular problem. And this idea of frame viability is the one where you look at the extent to which an explanation for, let's say, these patterns of COVID are salient and politically, culturally salient, meaning that they're consistent with the way that we understand the world. So if you're used to understanding health problems through the lens of, well, the reason that some people are more likely to die from COVID is because they tend to be older and more frail and so forth. Well, that's pretty consistent with how we think. Or the reason that, that's a pretty straightforward one that may have some validity as well. But when we get to racial explanations, and I'll get to those in just a minute, some of the explanations can be a little more difficult to sort of make sure that they are actually not just viable, meaning consistent with the way that we think. But the bigger question and the more important question that we've got to ask is, are they actually valid? Are they empirically true? Are they consistent with the data that we have? And what we've been seeing, and the reason that this piece was so important for me and my team to write, was that we're seeing a lot of the evidence of policies being done based on what's politically and culturally salient, not necessarily what the data actually suggest are actually who's at risk and who's dying and where the resources need to go. And so it's important to use valid frames for explaining the information that you have and using that to decide how you're going to aggregate, disaggregate, lump and split, if you will, the data that you have to make sense of it and to apply it to a particular problem and how you're going to approach that particular problem. So that's why I wanted to talk about this idea of framing in the time that I have with you today. So what I'm going to do is basically walk through each of the three pieces briefly that I was just talking about: race, place, and gender. Yes, I know sex and gender are different. We'll get to that in a minute. I won't, in the time that I have with you, try to get too deep into that. But I do, yes, I very much acknowledge that race and ethnicity are different. Gender and sex are different. We'll talk about sort of the interplay between the two. But yes, I do recognize that, and I'm not just sort of, I know I'm slipping back and forth, but in the interest of time, I didn't want to get into the weeds too much with those things. But I'm going to talk first about race, then place, then sex and gender, and then try to bring them all together before we sort of open it up for Q&A. So part of the reason I wanted to start with race is because when you initially saw some of the original issues with COVID and race, and Rudy Gobert got in a bit of trouble for the way that he handled finding out that he was positive, and actually the risk of COVID in the first place, and was making jokes and touched all the mics and so forth. When we were early in the epidemic and the pandemic, really thought of this as really not a big deal. So I'd gone to a meeting, for example, in early March, and basically there was no idea of sort of social distancing. The biggest thing that we were trying to do in early March was simply just not shake hands. And if we did that and washed our hands frequently, then everybody was okay. But there really wasn't all this attention to social distancing, wearing masks, and doing all those kind of things. What was interesting and through the lens of race, though, is initially the way that the stories came out is that Black people were supposed to be invulnerable and not able to contract COVID. And so it was these ideas that, oh, he had tested positive. Well, how is it that Black people can actually test positive? Initially, the stories were that Black people were immune to this particular virus. And so then it became, well, then the story shifted from Black people were immune to it to then became that Black people were now hyper sensitive to it. And then that was actually more consistent with the data. And is it something about being Black and biologically about being Black or whatever that means? Or is there something going on that actually is a larger explanation that we really need to pay more attention to? And so when we looked at the data and we see these kinds of things where we're looking at it by, again, race and ethnicity here and some of the CDC data, you see these patterns of who actually contracts it and so forth, the number of hospitalizations. And then we start to see the devastating impact when it came to deaths and mortality. In the interest of time, not going to break it into, and we've had a lot of issues with sort of the way that certain groups are represented or not represented in our data systems. And now that's been a constant issue, both with COVID as well as just with other general issues. I do want to highlight, particularly for our Native populations, American Indian, Alaska Native, Native Hawaiian populations, they're often the ones who are most affected by these kinds of issues and yet least represented. So that's why I at least wanted to acknowledge that here. But you also see that, of course, populations of African descent who've gotten a lot more attention, but no less more attention in terms of resources and concentrated resources to address their issues and their increased risk of not only contracting the virus, but actually of dying from it. But the question is not sort of, okay, we have the data and the valid data that says, okay, for some reason, African Americans and Native Americans are contracting the virus at higher rates. But we're also seeing that they're dying of higher rates. Now, how do we explain that? How do we understand that? And that's kind of the major focus of what I want to sort of walk through today. Let me go to place and then gender and then come back to this idea of race in just a second. So one of the ways that we've thought about this is place and concentration of particular populations, as well as sort of where certain places are contracting the virus at higher rates. I live in the Southeast in Tennessee, and we, as usual, have the distinction of having, not only the highest rates of chronic disease for the most part, the lowest rates of life expectancy. Usually, you have the typical sort of Southern sort of diet that usually is not the healthiest of options. But there are a lot of other factors that go into the risk factors for African Americans and for populations just by risk. And so we saw these really striking patterns as the virus started to come into the country and really make its way through our populations, that it started to cluster in certain places. And so some of that, again, how we explained why it was so rampant in certain places, yes, has to do with the policies that they enacted, but it also got to, we saw some of the explanations initially before we started to focus so much on some of the state level policies, on the explanations that maybe it had something to do with the biology of those particular groups that tended to be more affected. Maybe it had something to do with the environment and the built environment and those kinds of things of where people were contracting it. Then you saw these patterns of deaths, and that even got more complicated because now you weren't seeing the same patterns of who was contracting it, also relating directly to, it wasn't the same relationship of the percentage of folks who were dying from it as those who were contracting it. And so you were seeing those differences by place. And so that became an important phenomenon. Yes, I'm only looking at state right here, but we can definitely go lower and see where neighborhoods and cities and so forth have different approaches. And so the last piece I want to add to this before we sort of pull these pieces together is this idea of sex and gender. And again, from the earliest days of the pandemic, we've known that men are dying at a higher rate than women. And we've recently written a piece that talks about some of the ways that we sort of looked at this through a clinical or biomedical lens, and some of these determinants, like the higher rates of chronic diseases, basically, that tend to co-occur with increased risk of mortality from COVID. So things like hypertension, cardiovascular disease, diabetes, those kinds of chronic diseases and so forth. These other sort of biological factors and risk factors, the binding receptors and so forth, the sex differences in immune response. And we know that estrogen tends to be protective, and for men who have lower rates of estrogen, that tends to be increase their risk and susceptibility to these kinds of issues. So there are all of these kind of factors that we've looked at. And so there's a lot of attention to, oh, it must be biological as to the reason that men are dying at higher rates than women. Then it became an argument of, well, it's got to be men's behavior or always men's misbehavior. So we know that men tend to do most things that are bad for their health at higher rates than women, or that put their health at higher risk. So we tend to use more illicit drugs, alcohol, tobacco, drive cars, recklessly backwards, all the kinds of things that would put your health and life at risk are the types of things that we know pretty consistently pattern across within men at higher rates than they do with women, including being less likely to go to the doctor. And there's some questions about, we can debate about whether or not men are less likely to go to the doctor when they're actually symptomatic. That actually tends to be the place where you see less differences between men and women when they're actually symptomatic. The differences between men and women in terms of seeking clinical care or medical care tends to actually primarily be when they're looking for preventive services and so forth. That's where you primarily see the difference, or just regular sort of well visits and so forth. That's where women tend to do seek care at higher rates than men. When they're symptomatic for minor things, women tend to be going to the doctor at a roughly the same rate as men. And so those are the kinds of things that we're seeing as these explanations by sex and gender. Again, a lot of attention to biological factors. And again, it's not to say that these aren't important and aren't relevant. It's to say that each of these explanations, however important, is limited. When we get into how these pieces start to come together, and you think about race, place, and sex and gender, and one of the things that gets complicated is, can you, within a body that has a particular combination of race, place, and gender, do the things? Is it equally safe for you to do the things that you're supposed to do, like wear a mask? Are there other consequences or contexts to you wearing a mask that we haven't necessarily considered with other groups? And so we had a lot of stories, particularly in late March, early April, of Black men in particular being afraid to wear masks. And when there started to be this groundswell of, okay, everybody needs to wear a mask, there were major concerns for Black men who were afraid that they would be perceived as potentially thieves, robbers, and so forth, or just strike other fear into populations when they go into a particular space wearing a mask, particularly one that looks more homemade, because of the concept of the context of that and the larger sort of assumptions about what it means to be a Black man in relation to those kinds of behaviors. We even saw this with some Black doctors being afraid to wear masks, both in a professional context as well as in a personal life. And so we had this nice story that, nice in terms of thoughtful story of a physician talking about the difficulty of him being a Black man and a physician and wanting to wear a mask and wanting to follow that order, but then being afraid to do it both in the hospital and how people would react to that, much less in his personal life and just in public, made it much more difficult for him to follow that kind of directive. Those aren't the narratives that we've seen get a lot of attention in this idea of this pandemic, where we're looking at the need to consider, well, it's not just race, it's not just being Black, it's not just being in a particular geographic area, city, state, and those kind of factors. There also are more sort of micro places that tend to increase or decrease your risk of being able to do things that are protective or at least helpful, and that can increase your risk just simply by being in those kind of physical places. But then you also add this layer of sex and gender, and that those kind of factors also play a big part in this, and that we have to look at, again, putting those pieces together. The choices of how we started to rectify, at least make some progress in these data sources were really not because CDC and other ones who control the data sources, and obviously you may have followed the more recent sort of phenomena of the White House taking some of the data away from, or the control of the data away from CDC, and certainly the reporting and so forth, the tensions that you've seen back and forth between CDC and the White House in terms of how they report, who controls the data, who controls that narrative, being really important. But one of the other things that was important early on in the epidemic that we were seeing in, again, March and April, was just the lack of disaggregating the data in ways that would actually make it useful. And so there was a lot of pressure, again, from civil rights groups and public health advocates and so forth, that were saying, okay, it's important to start breaking these things down by demographic factors that matter, or different types of things that matter. So we need the data by race. We need the data, that helps us better understand who's getting tested and who's not. And we need it to map onto the different behaviors and steps that we're trying to do, both from a policy standpoint, as well as from the practices that we're trying to encourage people to engage in. And so then there was a lot of attention to, okay, well, let's also release it by zip code. And there are interesting sort of challenges with doing that as well. One is it can, when you actually have data, and this is beyond just COVID, that's looking at it by zip code, there can be essentially a place-based stigma that comes with having a particular zip code associated with these worse health outcomes. I do a state men's health report card, and we were strongly discouraged, for example, from presenting data by particular geographic locations like zip codes, like counties and so forth, that mapped onto particular locations that were that narrow, because they were afraid that the powers that be could use it, or people just in trying to do things like actually locate a business, that they may decide to locate a business or disinvest or do those kinds of things with that particular area if they're seeing that folks are particularly struggling as it relates to their health in those areas. So while place can be a useful way to look at a source of data and to direct resources, and ideally that's why people are wanting that information, it can also cause consequences where people are saying, well, that place is too sick. We don't need to invest in it. We're wasting our resources by investing too much in there. And so we just need to take it where we actually are going to do more benefit rather than throwing good money after bad, if you will. So this question of why there are disparities in COVID-19 mortality has to take into account all of these different ways that there are differences in COVID-19 mortality. And you may have noticed that I've kind of gone back and forth between differences and disparities. And for those of you who are sort of into those kind of language things, the reason is because some things we agree on are differences that are modifiable and that are things that are a result of policies and practices that we've created and therefore we can do something about and that we actually care about. Versus differences are things like, are there differences in COVID-19 mortality for those who have green eyes versus brown? Usually not something we care about, but those kinds of things would not necessarily rise to the occasion of being called something like a disparity. My other regular sort of example of a difference versus a disparity, many people are not blessed to be left-handed. I believe actually Dr. Goodman is, if I remember correctly. But I and others are. And, as much as that gives us an advantage in many ways to the world, that's not often thought of. The fact that most of the structures in terms of, in my day, growing up with notebooks and so forth, and other things that are structured like desks and so forth when I was in elementary school, that are designed for people who are right-handed, that our society is not structured to support people who are left-handed. That's usually not a difference that we can get a whole lot of support for. There's not going to be a rally for left-handed people, and sadly to say, for me. But the point is, there are things that we care about, and we have to look at data by the kinds of things that we're making a decision, and a political decision, that we care about certain differences mattering and certain differences not. And when we do that, it's important to recognize that certain things that we care about may not always map onto the differences that are actually consistent with the data. So what I mean by that is when we go back to, these issues with the rates of coronavirus killing men at twice the rate of women. Men's higher rates of mortality and rates of premature mortality, men are more likely to have a shorter life expectancy than women. That's not something that has really garnered or is consistent with this idea of a disparity, because the way that particularly Healthy People 2020, and I believe even there's been some modifications for 2030, and N.Y.C has come out with their own new definition of disparity that addresses some of this. But historically, the definitions of disparities have focused on populations that are disadvantaged because of the marker or the proxy or the factor that you're looking at, like race, like gender, where there are disadvantages in society and their structural disadvantages like discrimination at multiple levels. Men certainly do not fit that bill in our society. Men are certainly advantaged in most areas of our society, particularly economically, socially, politically, and so forth, yet have worse health outcomes. So it's been a difficult challenge to say that, well, how do we better understand what we need to do when men have a higher rate of mortality from things like COVID and other issues? There tends to be a more difficult framing an issue with how do we garner resources when women are disadvantaged in so many ways in our society and structurally disadvantaged in our society in so many ways. And so there's this idea of we need to put more resources into men and how we understand men dying of COVID at higher rates than women has been a really difficult thing for us to garner support for. And yet it's a really important part of the picture for how we need to better understand where and how to intervene as it relates to COVID. So where I was going with this is, I can explain the disparities by race. We can explain things through the lens of place. We know that the race differences that we see are mostly due to racism, and I'm sure Dr. Jones did a wonderful job of explaining that. We know that the place differences in terms of who has access to being able to not work, who has access to particular services that can help keep you safe and protected, who has access to testing is not equally distributed in our particular geographic locations. The policies that we have at state and local levels to support and protect people from contracting the virus or transmitting the virus are not things that are equally distributed in our countries, and certainly in states. Certain states have done a very active job, a very intentional job about doing that. Other states have decided that wrestlers and other entertainment folks are essential workers, and therefore they also needed to be at work. And it wasn't, essential workers were not just sort of healthcare workers in sanitation and other systems that we needed to keep going. So when we make those kind of assertions, how we explain those kind of differences in terms of race, place, and gender can give us limited explanations. But the question I'm asking is, if we know that all three are existing, what does it do to your explanation if you consider them simultaneously? One of the challenges that we've seen historically with a race-based explanation is that usually it has some suggestion as it relates to genetics, and it suggests that there's a genetic explanation or biological explanation for the fact that a particular race group is seen as having a higher rate of contracting, dying from a particular disease. And we know that those tend to be very limited explanations and tend not to map onto the categories that we're describing as races in our society. We know that the explanations by place tend to usually, again, demonize the place and attribute negative characteristics to the place rather than looking at the policies that are guiding the increased risk and opportunities for resilience that places may have. When we look at sex and gender, we know that those kinds of things we tend to look for gender differences through the lens of, well, it's men's misbehavior. It's men's likelihood to do things that they're not supposed to, or that put their health at risk, and therefore that's why men tend to die at higher rates than women. So we don't need policy change, we just need men to do better. And I can't tell you how many times I've heard that explanation as well. But the problem is, again, each of those offers something very limited. What happens when you put all these explanations together will hopefully give us a richer picture to how do we explain these particular disparities. Some of the ways that I want to sort of move to closing my remarks is sort of to look through particularly the lens of race, and there's been a lot of good work that's been published recently about some of the limitations of explaining race, COVID disparities through a particular limited lens, like just looking at race. And this was a piece, I believe, in JAMA a little while ago that was talking about the challenges of explaining racial disparities in COVID just through the lens of race. And often, again, as I mentioned, these data that are looking at racial disparities in COVID can give rise to biological explanations that we know simply do not hold up when we look at the other factors that may be contributing to why there are differences by race. Looking at these things through the lens and through this particular lens can also lead to stereotyping about behavioral patterns that actually tend to suggest that people don't really recognize the constraints on people's agency or ability to engage in certain behaviors to either protect themselves, keep themselves safe, and so forth. And so there are those kind of explanations that can also follow these race-based explanations when we look at data simply through that lens. We lose the context in which these things are shaped. Then you also, again, have these place-based stigmas that can come with geographic disaggregation that, again, without looking at the context of what else is going on in that place. How do you actually see the factors that are contributing to what's happening in those places may be something that we need to consider. And it also, can limit how funding is actually distributed. If the particular policymakers, at a particular time are not aligned with this idea of, or have a particular understanding of why these racial disparities in this particular virus, mortality from this particular virus, if they explain that through a particular lens, they're far less likely to see it being worthwhile and being politically worthwhile to dedicate resources to those particular groups and to looking at particular issues by race, because their explanations of it are consistent with the fact that It's just, it doesn't matter about policy. It really matters that folks are doing the wrong thing or not doing what they're supposed to, and that we should just be able to police and govern ourselves. And so with enough personal responsibility and individual choices, that people should be able to make their own choices. And not everybody has those kind of opportunities. But these kind of racial explanations, when you just look at them in isolation and absent the larger structural context, can be used in this way to adversely affect how resources are distributed to address issues like COVID. The genetic explanation I just want to touch on briefly, because it did come up very early on and does consistently be, is something that we consistently see coming up quite frequently, that the genetic explanation for something like COVID or for pretty much any disease is limited because it often doesn't take into account some of the basic conceptual flaws with just looking at a genetic explanation for a disease. Meaning that genes are rarely expressed without some kind of environmental context. What that means is you may have a particular genetic predisposition for something, but it's not just whether or not you're born with something. In a lot of cases, the diseases that tend to be kill people at higher rates or tend to be the ones that are most life-threatening are not just the ones where you have some risk for a particular disease, but it's actually the ones that have to be expressed with your particular experiences and the way that you live. It's kind of the nature versus nurture sort of argument, that without the nurturing, without the triggering of some kind of environmental context, we're likely to not see those genes actually expressed. Well, racial explanations and these genetic explanations tend to suggest that it's the gene, it's the presence of the gene, not the expression of the gene, that's triggered in the environment or by people's experience. And what I'm saying here is that it's really the environmental context that's triggering the gene expression that we have to pay attention to. And we also know that, current racial groups can't really be defined genetically. We're still trying to do that quite actively. We're actually trying, but a lot of folks in the field are trying to do that and consistently tried. We can get into all of the challenges with ancestry markers and all those kinds of things. But we would learn something about race and ancestry if they could be defined genetically, but that would really tell us something about the genetic basis of disease, not necessarily about the genetic basis of race. So we have to understand, if you're looking at something and you're trying to explain a particular disease, even if it does have a genetic basis, do the genes that are for that particular, that trigger or that make people at higher risk for that particular disease like COVID, is that something that maps onto our contemporary racial groups? And usually they do not. That's the point. Let me just close with this. We've seen a lot of modifiable factors that contribute to who's dying of COVID. And this is just an example of, it's not just about, so this was an example of this man, Gary Fowler, who had gone to the doctor, who had been complaining of symptoms from fairly early on. If you remember earlier in the epidemic in the United States, that we saw a lot of folks that had very difficult access to getting screening and testing for COVID, and you had to have a certain level of symptom and symptomatology for people to actually get tested and screened, and that was part of the reason why the virus was spreading at the rate that it was. And when he went to the doctor, he kept asking for help, saying he was having these symptoms, begging for a test. And you had lots of people who were doing that and they would get turned away. And nonetheless, he died from it. You had a lot of folks who, within the medical community, who were still, treating someone as though, well, there must be other explanations of why he's particularly at risk for these kinds of things. And we don't need to sort of worry about that. But these kind of biases can play into some of the choices and some of the subjective choices that people may have in different roles, whether they're medical providers, whether they're policymakers, depending on whatever role that you're in our society. Those kinds of blind spots and biases can really shape the choices or the things that you're going to do or not do to actually address this particular pandemic. So without sort of going through this, let me again sort of close where I started, which is that COVID has revealed that there are numerous weak points in how we think about health and how we prepare for disease, how we've created a system, a population health system that includes our medical system, our public health infrastructure, and hopefully how the two systems work together. We know that they don't work together terribly well, and that population health is the idea that you have an umbrella sort of way of looking at where the public health system, the medical system, and the gaps between them are all interacting, and how we need to consider all of those factors simultaneously. But all of those are dependent in relation to COVID. They're dependent on how we understand this idea of why are certain people at more risk for COVID, and therefore what do we need to do about it? Why are certain people contracting the virus at higher rates, and why are they dying from it? And is that, if we explain those kind of differences through the lens of, again, personal choice, responsibility, agency, we get a different explanation, or even something like genetics. You get a very different explanation, you get a very different policy response than if you explain it through a lot of the other factors that we're talking about, like some of the structural factors, like larger policies, like whether or not certain states are mandating that you actually wear masks, or certain locations are mandating whether you wear masks, or whether you social distance, and those kinds of things. Some of the things that are controllable, but we have to be willing to have these uncomfortable conversations, these difficult conversations, if indeed we're going to control this pandemic and have a healthier world. So with that, let me stop there. Thank you.
Thank you so much, Dr. Griffith. I feel honored that I have friends that can pull something like that off in less than 24 hours notice, but I know some really smart people. That was amazing. Let's start with a couple of clarifying questions. So someone asked if you could clarify your analogy that you use to explain the difference between differences and disparities.
Yeah, differences are things that we, so it's a gap in numbers is a difference. A disparity is something where there's a gap in numbers, but we actually both care about that difference that we're actually seeing. We actually value the populations that are having the different rates of that particular problem, and that we actually see the problem as something that's modifiable. So a concrete example, again, is if you think about the difference between young people dying from breast cancer, or no, that's a horrible example, dying from a particular chronic disease at higher rates, at lower rates than older adults. The fact that older adults are likely to have a shorter life expectancy than someone who's younger is not something that we see as a disparity. It's something that we see as a difference, and we're okay with that difference for whatever political and cultural reasons that we see as okay. But if people are of the same age, live in the same place, and we see that they are not having the same risk or likelihood of contracting a particular issue or dying from it, those are things that we often see as both as modifiable. There's a question about why does that difference actually exist? And there are things that we can actually say, okay, we actually want to do something about that. So my analogy, my silly analogy of left versus right-handed people is, again, if we find that lefties, tend to be immune to COVID, for example, which we know is not, unfortunately, not true. I don't think that there's not going to be this sort of effort to sort of protect and support those who are left-handed. We're just not going to get that kind of attention. But if you actually see these kinds of things that are differences by sort of left and right-handed, that we would actually want people to, that's just not a difference that we care about. We care about differences by race, by sex, sometimes by place, particularly if we can understand those differences in a particular way.
Someone else had a question for you to clarify when you talked about the genetic differences between men and women contracting COVID.
Yeah, so there are lots of questions about why men and women are contracting COVID at higher rates. And we don't have good explanations for that. What I was pointing to and what some of the pieces that I sort of just were highlighting that others have written and that we sort of we included in our piece were some of the biological markers that differ between men and women that are either genetic receptors to the virus and so forth, or that are other factors that may be contributing that are differences between men and women. Those are the things that we sort of have identified that sort of increase risk. And we know that those things are different between men and women. So that was the only point, is there's been a lot of attention to studying those factors, and we've seen that pretty consistently across different countries.
I'm going to give you a question that I think you will love.
Oh boy.
What's your strategy for addressing men's health? Do you recommend focusing on health prevention programs?
Ooh, God bless you, whoever asked that question. No, I'm just kidding. I mean, I think it's the challenge with men's health is often, yes, we do need to do men's health promotion programs, but I think part of it is also the lens that we use to design those programs. So part of it is, how do you understand the way that men understand what it means to be healthy or not? And so if, it's not just, one of the examples I often give, part of the reason that men don't go to the doctor is not because they don't like the doctor, it's because they don't find going to the doctor valuable. They don't get any information that they didn't have before. They don't really want they like getting the information like from tests, medical tests and so forth. But a lot of times they're getting information like lifestyle advice, or they're not getting sort of treatment or support or getting their questions answered in ways that are actually helpful. So I think we have to map the way that we think about health, which is men tend to define health more through their ability to do things like be intimate with a partner, to do things like being able to go to work, to have energy to do things that they care about, play with kids, do those kinds of things. So we need to frame the messages, the information that is for men in ways that are consistent with how men are going to receive that information, and then design things and put them in places where men are likely to receive that. And that usually means involving men in those conversations and not just deciding for men where to involve them in those places.
Someone else asked if you could review your elephant analogy again, which I think is great, by the way.
Oh, thank you. The simple point is that, there are a lot of articles that are out there that are saying we need to disaggregate data by race. And the answer to solving the COVID epidemic in the United States is to data aggregation and to focus the efforts that we have on racial differences and who's actually contracting the virus and who's dying from it. Others are saying, no, we need to focus on place. We need to focus on the states that are not enacting very aggressive policies to protect their populations, that are not doing things to support the kinds of recommendations that are wearing masks, contributing social distancing, doing those kinds of things. But it's all about place and those kind of factors. And then others are saying, no, the answer has to do with gender. And the fact that, women are in, I think there's an interesting story a few months ago that was saying that while men are in sectors, men are a larger percentage are employed at higher rates in a larger percentage of sectors that are considered essential workers. When you look at the raw numbers, because of the disproportionate number of women in helping professions and medical professions, that women are overwhelmingly the population who are essential workers in those populations, the numbers for women are greater than that for men. The point is that when you think of it through those lenses, it's only looking at each one separately. And what I'm simply saying is each one is a limited lens. If we just deal with race, we're not going to deal with gender. If we just deal with place, you're going to still see this exacerbation by race and gender. So we have to deal with all three of these, as opposed to just saying the full elephant of COVID is just about race, is just about place, or just about gender.
Dr. Onpa, do you have any questions? Sorry, I'm trying to filter through the many.
No. I think this is a really provocative question and probably one people have had all week. Given the drawbacks that you mentioned about collecting health data by race, is it advisable to continue to do so, and why or why not?
It is advisable because it helps. The data by race helps you understand who's still being served and who isn't. So we still need all of the data disaggregation that I was describing. We need data disaggregated by race so that we know if there are differences in who's actually getting screened, who's actually getting treated, who's actually contracting, dying, and so forth. And we need to look deeper into those explanations. Same thing with place and same thing with gender. So we need that because it's a useful way to get to track who's actually being served and are there differences in our society by those kind of factors. And we know that there are unfortunately differences by race in access to resources and opportunities to do things like screening or to get sort of useful information or to actually get same quality care, that those have mapped by race. So we need to continue to do that. We just need to explain it when you see it through a particularly different lens that considers that there are other things other than genetics that may explain why the virus may be, people may be dying of the virus at different rates than those of different races.
What kind of interventions do you suggest we could do at the local, state, and or national level to address gender-based disparities?
I think first is just recognizing that there are differences by gender and considering, one is actually to present the data by gender and to actually look at it and see where there are actually differences by gender at each of those levels. The second is to look at the policies and are they differentially affecting men and women, and whoever's doing worse, can we dedicate more resources or better look at how those resources are being effective for those particular issues by gender. So it's called gender mainstreaming, which is basically using gender as a primary lens, or at least one of the lenses through which you actually consider whether the policies are actually having an equal benefit to everyone who's being affected by the virus. I think we have to look at, again, this idea of essential workers. The complicating factor of, again, women being higher rates of medical professionals, helping professions like social work and so forth that have been overburdened with COVID and the related issues in COVID has to be something that we consider in this pandemic. We have to deal with a lot of the gender-based violence that we've seen really take, unfortunately, a huge rise in our population. And so all of these different things we need to take into account through this gender lens at each of these levels to really consider that. So I think the main thing, though, I would say is to look at the effectiveness of policies and who's benefiting from policies by gender, and to do that consistently at each of these levels.
How much do you think bias and the microaggressions that Black men encounter in the healthcare settings also deter them from seeking healthcare?
I'm sure it plays a part. For most Black men, unfortunately, that's not a new phenomena. So it's kind of, it's not that you expect it. It doesn't make it any easier to take once you do experience it, but it's not usually the main deterrent of whether or not somebody's likely to go get that kind of particular service and support. So Black men are still, despite the fact that they know there's a good chance that they're going to face less than the best quality care, they're still willing to go to the doctor. And so the question isn't that. The question is whether or not, the services can actually exceed their expectations, deal with issues of distrust and mistrust that are actually legitimate, and provide them the support and the information they need to allow them to live healthier lives and to get the resources that they're actually seeking.
How might we address / correct the issue of the media's oversimplification of these disparities, race, place, and gender, when reporting disaggregated data?
I would love to say that I have a good explanation for that. I know some colleagues of mine, there's a paper, for example, by N.Y.C, I think she did probably 10 years ago, where she was reporting that the media tends to look for, or tends to simplify, particularly racial disparities data, into things that are about personal responsibility, individual behavior, or genetics. And so it's not unique to COVID. It's something that has been a consistent problem with how we report these kind of data regardless. I think it's just giving, working more closely, or having journalists actually be, have folks who can help give them more substantive answers and explanations and strategies for them to make for, academics like a Dr. Goodman and some of the other folks that you've actually had, as speakers, to actually be available to speak with folks and to give them a richer explanation, understanding for these kind of issues. I think it's just developing better relationships so that when they have questions about how do they explain different things, that you can actually come up with a way to do it that gives them that information and allows them to come to present a better and more rich explanation for how they need to address these particular issues.
So one person has asked, to what degree are gender-based differences also tied to patriarchy, i.e. men are stronger and need less medical attention, women are weaker and need more support?
We haven't seen that necessarily. I mean, that's always a context. Let me start with that. And again, those stereotypes, assumptions that we know are completely false, let's make sure we put that on the table first too. All of what you said is completely false. Men don't have any of those advantages, and women are not those things that we just described. So let's just make sure that that gets on tape too. So the assumption, again, the frame, again, if we go back to that women are these, physically weaker beings, when actually we know that biologically women tend to be physically stronger, or, immune system and so forth tend to actually be stronger beings than male organisms from birth to death. That has not played a part as strong as just some of the other factors that I think are more social and structural, in terms of we haven't really considered this gendered lens of, the kinds of places and the ways that men are actually engaging in or contracting the virus, and certainly not being treated for it. And so a lot of times when you saw again, I gave you the example of the gentleman in Detroit who had gone to the doctor, and you saw a lot of these cases where I don't know that there was necessarily, it would be interesting to see if there was a difference in how the medical community responded to men versus women when they went to the doctor and reported that they were symptomatic and wanted tests. Were they being turned away or treated in different ways by that? Or was it just that there were differences in who actually went to the doctor in the first place? My guess is it's a combination of the two. So I guess I would not want to simplify it to something as important as patriarchy, but I would say that definitely plays a role in how certain people would frame that particular issue and problem. But I would say that there are other things in how those kind of systems or approaches or that cultural lens shapes what kind of services are available to men and women, and how we need to address those kind of things going forward. So the fact that we don't have a lot of clinics, you can get a degree, a public health degree in maternal child health, but you can't get one in something related to men's health. Those kinds of things that you have particularly developed expertise in how to understand the gendered experience of women's lives, but you don't have that for men, does mean that we have a workforce that tends not to understand men from the perspective of men in the way that we do with women and women's health.
Someone just asked a clarity question about whether the data that you presented contained only US citizens, or were non-citizen residents also included?
Which I'm guessing it's probably the CDC data that you're referring to. I'm not sure which data they're talking about. So yeah, I was reporting basically what's already been sort of out there reported. I'm not sure that they disaggregate that way in terms of citizenry. So I would have to look back at the original source.
I don't think they do, but whether or the person was also asking about whether or not there were undocumented individuals included in the data, and they don't ask about that. I know for the CDC data,
Right.
it would be a deterrent for people participating.
And it would be a political nightmare for those who are actually reporting it to actually be able to say that they're giving services to people who are undocumented.
Exactly.
Someone asked about clarity on the estrogen effect on COVID.
So I think it's just my understanding, again, this is getting dangerously outside of my area of expertise, which is why I had colleagues who wrote that part and were speaking to that. My understanding is that estrogen tends to lead to a stronger immune response than, or higher levels of estrogen tend to lead to a stronger immune response, and therefore are better at helping to fight things like a virus like COVID. And the receptors, they're ER positive and so forth negative, the estrogen receptors are things that they've been looking at as potential things that help to differentiate the rate at which they exist in women versus the rate at which they exist in men, have been things that they've identified as potential factors that contribute to why men are likely to die from COVID at a higher rate, or at least contract it through that particular mechanism, that biological mechanism, at a higher rate.
So this question has actually come up a lot. I've been asked this from media folks. To what extent do you think that who gets a COVID-19 vaccine first should be based on disparities?
That's a great question. I guess my first question would be, when you say disparities, do you mean race? Do you mean place? Do you mean, like, how do we decide which disparities we actually are seeing as most important? And is it combinations of, say, race and gender that we would sort of look at as who should get it? Yeah, that's a harder question for me. I think I would probably want to see those who are at higher risk, or those who are, yeah, that's I don't know how to answer that, honestly. That's a tougher question, because part of me is thinking, well, if those who are sicker and are more immediately likely to contract the virus and have it be more severe, then I would want them tested first. I'd want them to get the vaccine first. We know that they're actually probably the ones who are least likely to actually want to get the vaccine, particularly in its early stages, particularly when it's seen as exploratory and so forth. But yeah, that's a much tougher question. So,
and I'll repeat the answer that I think this question was asked, a similar question was asked yesterday, and I'll repeat the answer that Dr. Jones gave yesterday, which is clearly no one wants to be in the testing pool. Mm-hmm. So once we have an effective vaccine, but her answer was that Black and brown folks should get it at the same time as the president and Congress.
I like that answer. I would support that.
And I would just add that often when there are shortages in vaccine supplies, what has typically happened is those who are most at risk. So when we've had flu vaccine shortages, mm-hmm. those who are most at risk, including older adults, those mm-hmm. over 65, those with chronic conditions, get the vaccine first, as well as healthcare providers.
Essential workers, yeah.
Yeah.
Yeah, so that makes sense to me as a way to go, but how then that maps onto, race, gender, those kind of factors gets far more complicated, far more political. So, yeah, I think for me, I would want just there to be transparency in the process. I think that's the biggest thing, that if you think about why people are likely to be uncomfortable with the choices once they actually get to the point where they're distributing the vaccine, that's usually one of the things that tends to make people the most skittish, is how are you making choices about that? And even if they don't necessarily agree with the choice, at least they understand the way that you're processing this and you're explaining who's getting the vaccine, as opposed to it being some kind of mystery, which then leads itself to a lot of other questions and concerns and conspiracy theories about all kinds of things.
I just want to take an opportunity to point out something important you've kind of been saying all along, and that is there's a lot of politics involved in this, and public health is highly influenced by politics, and what can and can't be done is not necessarily always based on the evidence that we present. It also takes a lot of political capital and maneuvering sometimes to do the right thing.
Most of the time, if not always, it's more, unfortunately, it's more what gets passed and what actually gets implemented in our society and then actually enforced are the things that, again, are politically viable and are culturally consistent, far more than necessarily what is in the best health and well-being interests of that particular population or of us as a country. And so there's always been the question, people have been saying for, decades now, that most of the things that we see as it relates to disparities, we really do know how to fix. We have the expertise to redistribute wealth. We have the expertise to get people care. We have the expertise to identify who needs different things. It's really much more about political will. And we haven't had the political will to do what's right. We've just decided to do what gets people elected or what keeps people in particular positions. But we haven't been willing to take those kind of risks, or the folks who have taken those kind of risks are usually not in those positions any further.
I'm going to rephrase this question because I know the answer. So this person asks, is COVID-19 uniquely racialized compared to other diseases? And if not, can you give some examples of other racialized diseases?
It's hard to think of a disease that's not really racialized. I mean, we tend to, most diseases. So in the U.S., and that's kind of why I was starting with kind of the global context, is depending on where in the world you look at this outbreak, there are different ways that different countries have framed who needs more attention, who's at higher risk, and how they explain those differences. We tend to look at things in the United States through the lens of race. Other countries, say Europe, they tend to look at things more through the lens of class. Some places there are different categories of races and things like, in Canada, they tend to focus more on whether or not folks are indigenous to particular groups or populations and areas. And that's a bigger thing than necessarily being of African descent or other sort of characteristics. So I think it's really contextual, which is why that's kind of been such a big thing of what I'm saying. But yeah, most diseases, I think we racialize because that's the way that we explain who's at greatest risk, and that we are able to then say, okay, we don't need to concentrate resources in that particular population. We need to give it to these others because there's nothing we can do for these people if they're genetically inferior and they're much more at higher risk. Then we don't need to put as much energy into them. We're just going to make them comfortable and safe and, let them, die in peace. But we're going to put effort into trying to help these other folks be healthier. And that's what we're going to do. But those are the kind of, choices that we make, unfortunately, in those kind of environments.
What types of policy interventions can address race, place, and gender simultaneously?
Ones that recognize that each one is relevant. And so I think it can be as simple as if you're looking at policies around which restaurants open and which areas are, what kind of businesses are actually opening. You can look at, are there differences by race, place, and gender to see if the businesses that are being supported or being hurt by the way that we're enacting certain policies, are they different by any of those factors or by the way that those factors combine? And then, so it's not necessarily that the actual policy may not necessarily need to be different. It's how you're actually targeting the resources that you're using that policy for may need to be different. So perhaps, if that, women-owned businesses, for example, are being disproportionately hurt by the pandemic, are there things that you could do to potentially consider how we need to support those businesses or provide additional resources or additional attention to those businesses, than the way that we just sort of use this one-size-fits-all strategy. Okay, well, let's just open them in a particular area. And if we know, usually businesses, particularly by race, are you know, race and place tend to be conflated in our society. They tend to be mixed up in the sense that, you know, people of particular races and ethnicities tend to live in a particular geographic area and tend to be clustering in particular geographic areas. So we know those two are likely to be things that are going to co-occur. So paying attention to that is going to be important of how you concentrate resources and where you put things like testing and supports and other things to ameliorate the problems that you're seeing.
This is going to be the last question. Besides the ones that we see across zip code, do we have data for other place-based disparities in COVID?
I mean, I guess when I was saying place, I'm using everything from zip code to, I know cities are approaching, you know, COVID with particular, you know, any kind of, I was considering place, anything where there's a jurisdictional role that a government official may have, or where you could actually look at data differently. So I'm thinking of in Nashville, there's a lot of tension between the governor of the state and the mayor about how they should do things like open businesses or not. And there's a lot of fighting with that. There's, you know, there's things at a county level that certain, you know, in other places where the counties are fighting with state, you know, about those kinds of things. So I was just using it very loosely. I know, you know, on a regular basis, when I see my little news feeds and so forth, we get all the differences in terms of states, and states are, you know, have different ways of, now they're, you know, you can't, for example, travel from Tennessee to, I think it's New Jersey or New York without quarantining for 14 days because there's certain states that are now sort of, you have these kind of, that's what I'm calling place, is all of those kind of things that speak to a geography, that those factors need to be considered. And which one is obviously part of the issue that we have to pay attention to, is which one matters and why.
Thank you so much, Dr. Griffith. This has been amazing. When I emailed you yesterday and I said I needed a bailout like working class Americans, I appreciate that you responded quicker than our government and bailed me out in warp speed. So thank you very much. If you guys want to flood the Q&A now with how great he was, you can do that. And we will see you guys tomorrow. Dr. Ompad, do we have any announcements before we end today?
The only announcement we have is for those students taking it for credit, we'll be joining the next Zoom shortly. And so we'll see you there. Tomorrow is our last class of this series. And just to reiterate, we are not providing slides, but we will be sending out an email with links to videos once they're ready to be shared. Sorry, that's my alarm.
The other thing I just wanted to mention is that Dr. Griffith is a co-editor of that APHA racism book that we showed you the other day, and he's also an editor of the handbook on men's health, which was up when we showed his intro slide. So check those out. See you tomorrow.
Bye, y'all. Thank you.